should go away. And if it doesn't, then we should not try to manage it on our own. So a little bit about the physiology, about the mother and the fetal interaction, transition in the postnatal period, and then the gluconeogenesis that is so important. So the mother supplies the fetus with the glucose, and this glucose is transported across the placenta via facilitated diffusion. It is not osmosis. It requires energy. And the fetus does not generate glucose. This is something that is important for all of us to remember. So as a neonate, as a cord is cut, the supply of glucose is cut off, and then the fetus sees, the neonate experiences a decrease in glucose. This is a part of transitioning. All babies will see this, but the level then rises back to what we think is normal in 2 to 3 hours, and by either feeding or by gluconeogenesis. The brain primarily uses glucose, but it can use ketones. Under difficult circumstances, it can use lactate a little bit, but that does not generate a lot of energy. And the head to the body ratio is high. So the brain primarily uses glucose. So the GIR is higher in the NICU as compared to the other places where they use 2 to 3 milligram per kg per minute. We use 5 to 8. So during starvation or when the cord is cut, let's just, I'm using the word starvation because this is just a term to use. Insulin should decrease. Glucagon level should increase, and it should make the liver release convert its glycogen to glucose. The hypothalamus should activate the sympathetic nervous system, release epinephrine. And the liver is very important for both glycogenolysis and gluconeogenesis. So there are three ways that the glucose can get into the bloodstream if the baby is not feeding, besides the IV that we infuse. The glycogen stored in the liver breaks down to glucose. Fatty acids are broken down, and amino acids can get broken down, and alanine is, the proteins can be broken down to amino acids, and alanine is the major amino acid that gets into the gluconeogenesis pathway. So this is what should happen. And then the baby should start taking milk. And this milk means colostrum. And colostrum has protein in it. Colostrum has lipids in it. It has triglycerides in it. It doesn't have a lot of glucose, but it has enough substrate that the baby is not starving anymore. So if the baby doesn't get good feeding, can that baby generate glucose from what is already present in his or her body? And we know fat stores accumulate in the 3rd trimester, glycogen also towards the end of pregnancy. And that means that the neonates who are at risk for not having good compensation until feeding is established are the babies who are either small for gestational age, preterm babies, and babies who cannot have the counter-regulatory hormones, and they will have a poor ketogenic response, and those will be the large for gestational age babies and infant of diabetic mothers. So this is what we usually see in our couplet care and the newborn nursery. Cord clamped, glucose supply stops, insulin should decrease, counter-regulation should step up, glucagon, epinephrine, growth hormone should go up, glucose level normalizes as the baby is feeding. So this is this is what should happen. So then we have some indications of which babies are going to get into trouble. And we look at illnesses besides the 4 high-risk babies that I've already mentioned, maternal medication, all that adds to the list of babies who can be hypoglycemic. And this list is important because just by looking at a patient, you cannot always tell that the patient is hypoglycemic. Sometimes you can, but not always. And you must have noticed by now that I have not mentioned any numbers for hypoglycemia. I will a little later, but there's a reason for not saying this is hypoglycemia. So birth asphyxia, during the prolonged labor, they use up their glycogen. Preterm infants don't have enough stores, neither do the SGA infants. Then the enzymes are immature, the gluconeogenesis enzymes are immature in the preterm infant. Lack of adipose tissue is seen in both the SGA and the preterm infant. Diabetes and macrosomia, a child who's large, unless it's a family history that everybody in the family is large and it's just genetic and they're all healthy, a large baby, you have to be very suspicious that the insulin level will be inappropriately high. And we know if infant of a diabetic mother, the insulin level is high. Similarly, the medications such as beta blockers, butylene, salbutamol, if the mother is obese, all these have lack of counter-regulation, and that means that the baby cannot compensate. Besides that, polycythemia, because there are a lot of red blood cells using up glucose, sepsis, high metabolic state, erythroblastosis fetalis, you don't see it anymore. This is also associated with hypoglycemia. And then genetic mutations. I am not an expert in genetics, so I'll leave that for the doctors to talk about tomorrow or day after. Now we come to what happens when the baby's hypoglycemia doesn't get resolved in the first 1 or 2 days or 3 days. So transitional hypoglycemia, and then now we are talking about prolonged and persistent problems. So prolonged hypoglycemia beyond 2 days or 3 days, the insulin level is inappropriately increased. So the broad categories will be endocrine, metabolic, and the genetic mutations or syndromes. These are the broad categories. Increased insulin, decreased cortisol, or problems with the adrenal gland, problems with the pituitary. These are the endocrine issues. And then coming to the metabolic, I've already mentioned we need glycogenolysis. So if there are glycogen storage diseases, fatty acid oxidation defects, carnitine defects, amino acid disorders, all that adds up. This portion, when we get into the prolonged hypoglycemia, as a neonatologist, as a primary care person, we can provide the glucose via infusion, but we should start looking towards the consultants to help us manage further. How does it present? There are autonomic signs and CNS signs. Temperature instability, tachycardia, hunger, sweating, the baby looks jittery, baby won't keep her feet down, she's vomiting, pallor, just looks shaky. And you can see that if there is poor feeding, it will worsen the hypoglycemia. She won't be able to keep her feet down. And then the CNS signs are lethargy, hypotonia, apnea, poor feeding, high-pitched cry, really a distressed cry, but it's now going to step towards convulsions and coma. So why do we worry about it? Because if there is true hypoglycemia, there is true brain injury and small head size, low IQ, abnormal MRI. And the reason why the duration of hypoglycemia or the level of glucose below which there is brain injury is not well defined is, one, the brain can use some alternate sources of energy like ketones and lactate, as I mentioned. So if they have the ability to generate ketones and use those, or the colostrum provides it, then the number of glucose, the actual number that you measure is not as important. The glucose may be 34, but the baby is asymptomatic because the baby has some ketones at the brain and the homeostatic mechanism is picking up. And the other thing is that a lot of diseases that cause long-term brain injury will cause hypoglycemia. So yes, there's a cause and effect if the glucose is low and the baby doesn't have a good IQ level or has microcephaly later on. But if there's a syndrome, then perhaps that syndrome is also associated with microcephaly or low IQ, or however you would like to say it, poor cognition. And that is, it's both ways. There is no clear-cut number. The number varies by postnatal age. And we can say mild or severe, transient or persistent. And we call it persistent after the first 2 days or 3 days after the stay in the hospital, really, if the baby was in couplet. So there are two schools of thought. One is the AAP, and that is what most of us deal with all the time. The other is the Pediatric Endocrine Society. The AAP has given recommendations mainly for the first 2 days. And they accept that normal neonates have low glucose levels that normalize when feeding is adequate. And they have published guidelines several years ago. The Pediatric Endocrine Society, on the other hand, usually sees babies who are truly sick with persistent hypoglycemia, because we don't call them day 1 or day 2. So they start by saying that babies should have a glucose better than 50 in the first 48 hours. If it's less than 50, it's abnormal. And they recommend much higher levels of glucose. I can explain the reason now and I'll repeat it later. They say that the baby should be able to maintain a glucose level of 60. And if you have a baby on a very high infusion of glucose, that should be 70. And their logic behind these recommendations is that if they cannot metabolize ketones, if they have metabolic disorders or they have difficult counterregulation and they cannot generate or metabolize ketones or amino acids, then their alternate sources of energy are not available to them. So the glucose level has to be higher. That is how they are saying. That's why the numbers are different. So AAP says that if this is an LG infant or infant of a diabetic mother, monitor glucose for 0 to 12 hours. But on the other hand, if it's a preterm infant between 34 and 36, 6 by 7 weeks, or an SG infant, then monitor for 24 hours, even if it is normal. Or at least 3 consecutive pre-feed levels should be normal. So if they say if the baby is symptomatic, and I've mentioned what symptoms would be, and the glucose less than 40, just go ahead and give IV glucose. And so they have split it into less than 4 hours after birth and more than 4 hours. And they expect the feedings to be initiated soon after birth. And because the cord is clamped and the baby the enzymes the counter-regulatory hormones have not yet become active, and the insulin hasn't had time to drop, that in the first 0 to 4 hours, feed the baby before the baby gets separated from the mother. So as soon as the baby is born, put the baby on the mother's chest, try to feed the baby. Check the glucose 30 minutes after the first feeding. If this is less than 25, refeed, and then check in 1 hour. If the second screen is less than 25, then start IV glucose. If the initial screen is 25 to 40, refeed. If it's still 25 to 40, you can still refeed or give IV glucose. And they don't give a limit on how many times you can refeed. That has not really been mentioned. When should you start IV fluids? I don't remember seeing that. We can give formula because the volume of feeding is more. You can go up on the volume. Let me go to this. The third slide from this one will tell you the overall steps for both before 4 hours and after 4 hours. So if the baby is 4 to 24 hours, the glucose is less than 35 now, the baby has fed twice, glucose still less than 35. They still say you can refeed and check in 1 hour. And if it is still less than 35, then go ahead and start IV fluids. So they're giving about 3 feedings. Feed in the delivery room, feed once, feed after 4 hours, once at least. And then if it is between 35 and 45, keep checking and keep checking hourly until it gets better. And finally, after 3 or 4 or 5 of these sessions, people get really tired and do want to start IV fluids. So if the glucose is not coming up, you've checked it, it's 35, you fed the baby, 36, checked it again, 37, that's not coming up. So don't spend time doing this. Now you've 35, you fed the baby, it is 43, okay, maybe the next one will be 48. So the numbers are 25, 35, 45. Just generally, you should remember these. Believe me, this will change when something new and grand comes up again. Because when I was training, it was 20 and 40. And there's a little more to this number besides the 25, 35, and 45. They are now saying that you should have lab confirmation. These numbers are not the POCT, point of care test. They are talking about lab confirmation, which takes some time to come back. So check glucose in infants at risk for hypoglycemia, all symptomatic infants. If the patient is asymptomatic, you can feed the infant more volume, perhaps more frequently, every 2 hours instead of every 3 hours. You can give 40% glucose gel or formula in addition to breast milk. No indication to stop breastfeeding, just supplement. If the patient is symptomatic and the glucose less than 40, don't wait, just start IV fluids. If the patient looks a little jittery but looks like she will feed, you can try feeding, but don't keep playing with that. So when IV fluids are started, we want to get to 45 to 50. And the 2 ml per kg D10 bolus given over about 5 minutes, slow IV push is what is, we initiate we start as the load and then put D10 at 80 to 100, and this gives about 5 to 8, a little more than 5.5 milligram per kg per minute of the dextrose infusion. Now, if a higher concentration of dextrose is needed, you can only give D12.5 via peripheral IV. So once you get to D15, if you can go up to on the volume a little bit, like maybe 120, 140. After that, there'll be so much fluid overload and hyponatremia, it's risky. Shouldn't do that. Just look for a central access, UVC or PIC or a surgical line. So D12.5 is the max concentration that you can give in a peripheral IV. Next question usually comes up, how are you going to wean the fluids? So we drop the rate by 1 ml or 2 mLs, but if the pre-feed glucose is better than 60, and I told you where the number 60 is coming from, that's where the Pediatric Endocrine Society really wants to maintain the glucose. And that glucose after IV fluids have been discontinued, and there is no recommendation to stop feeding, except in certain cases, such as a hyperinsulinemic baby, where when we feed, the insulin surges so much after the bolus feeding that the glucose drops, doesn't pick up. So there sometimes continuous feedings are better than bolus feedings. And TPN has leucine in it, and protein helps the reuptake of glucose into the muscle. This leucine helps the glucose get back into the muscle. So it actually, sometimes it's better not to give TPN, just give just D10 quarter chloride, sodium chloride, or acetate. So plasma glucose is going to be a little bit higher per ml, because in 1 ml of blood, there is space occupied by the cells. They're not contributing to the glucose measure. Similarly, polycythemia lowers the blood glucose measures. And point of care instruments are not that accurate. So you have to accept that they may even be 15 milligrams above and below what the lab value is. So that is important to remember. If you're getting a 40 on a POCT and the lab comes back 25, that 40 was wrong. You don't accept the POCT, you have to go by the lab value. You have to call the lab, make sure it doesn't sit over there for a long time and the cells keep eating up the glucose in your specimen, but you have to go by what the confirmation is. So that's why you order lab stat. This is just, I thought maybe somebody would find it interesting and if they want to really calculate the GIR. So GIR is measured in milligram per kg per minute. So 10% glucose means 10 grams of glucose in 100 ml of water. Does that make sense? The 10%, 10 grams and 100 means 0.1 gram. So similarly, D12.5 is 12.5 grams and 100 ml of water and 0.125 grams. So that comes to, that is when you convert it to milligrams, it's going to be multiplied by 1,000. That's where the 1,000 comes in. So 0.1 grams converted into milligrams, multiplied by the 80 ml per kg, divided by 1440, that is the 24 hours times 60 minutes. So that's where these numbers come from. So how to calculate the GIR. Okay, and the most common problem we see, infant of a diabetic mother, infant of an obese mother, hypoglycemia is a problem, hypocalcemia, electrolyte imbalances with calcium, magnesium. They're big babies, they get stuck. So there's birth trauma. They have immature surfactant or inadequate surfactant. So they can get RDS. They can have cardiomyopathy with intraventricular septal hypertrophy, an outlet obstruction, sometimes VSD, transposition of the great arteries. They have caudal regression if the mother is very poorly controlled in the first trimester. So the lower portion of the body is not well made and they can have very small legs, and that's what caudal regression is. Or they can have spina bifida and anencephaly. This is seen frequently, the small left colon or meconium ileus that can be seen, and they can have malformations of the intestine. Now, the Pediatric Endocrine Society, I had already mentioned, they say maintain blood glucose better than 50. After 48 hours, maintain it better than 60. And then they also recommend a challenge of starvation, where the baby should be able to maintain its glucose better than 70. If this is done, it cannot be done just by ourselves. The endocrinologist has to be there supervising this. And usually, if they want to do it, they would do it with the special formulae that the patient, the diagnosis has been made, why the patient is having hypoglycemia, the patient is being given the correct treatment, and then this step comes in. So we are not doing this. Okay, so I've mentioned the maternal history and the risk factors. Now, could it be another illness? Could it just not be isolated hypoglycemia or a metabolic or an endocrine disorder? Could it be just the baby is ill and has sepsis? Could it be the baby has bled in the head? Or is it the baby's jittery now because there's drug withdrawal? So there's a differential diagnosis of that you don't just say, okay, the blood sugar is low, I'll fix that part, but after that, it's only endocrine or only genetics or it can't be sepsis. It can be sepsis. Sepsis and hypoglycemia go hand in hand. So don't forget that part. Do check a CBCD if you can't fix it with feeding. And I've already mentioned, when do you call an endocrine? The GIR is very high, and start thinking about a central line if you need more than D12.5. The critical sample is, endocrinologists say that you should send it when the glucose is less than 50. And since they are going to be managing after that, we will go ahead and order what they ask us to send. And there is a list of things. Before that, let me mention hyperinsulinism, because besides being an infant of a diabetic mother, there are other babies who have increased insulin. LGA babies, SGA babies can also have increased insulin, inappropriately high insulin. And there are receptors on the pancreatic beta cells that are called sulfonylurea receptors, the oral hypoglycemic agents that are used. The same name is given to that receptor. And these receptors are, if they get depolarized and sodium and calcium enters the cell, degranulation occurs and insulin is released from them. So these receptors are abnormal, or they are genetic defects, then with abnormal entry of calcium and release of insulin from the beta cells. And the 11P is a locus which is important. And Beckwith-Wiedemann has a problem at this on chromosome 11, the small arm, that can be associated with hyperinsulinism. So there are multiple mutations, and then there are tumors, there are syndromes, Pullman and Soto's. These are all big babies with hyperinsulinism and sometimes cardiac defects. So other signs besides the autonomic and the CNS signs are large baby, or a baby with the signs of Beckwith-Wiedemann syndrome. Large baby omphalocele sometimes has hemihypertrophy of the body, and ear creases, or the baby can be small with abnormal genitalia or midline defects, and hyperpigmentation, and I've mentioned the other diseases and metabolic disorders. So any questions so far? So when should we investigate further? Persistent hypoglycemia, severe hypoglycemia, abnormal physical exam, sick infant, especially with metabolic acidosis or hyperammonemia. And then I've just written endocrine and metabolic, but genetics is also very important. These two came to my mind because we wait to send genetic tests after we've consulted endocrine and a metabolic specialist. So is it insulin excess? Is it deficiency of the counter-regulatory hormones? Is it an inborn error of metabolism? Is there increased utilization because of heart disease or sepsis, or being of cold stress or asphyxia? Is it a genetic syndrome? Now these are just steps, and depending on what is available, what are the common tests that are sent in your hospital, you can adjust these. But we always send a glucose level and an insulin level and a cortisol and a growth hormone level. We should also send a blood gas. And because we send blood gases so commonly in the NICU, we forget to mention blood gas is a part of the workup. And then ketones, that's the other thing. So the second stage is the hormonal tests, which are more advanced, and we've already called endocrine by now, ACTH, free fatty acids, ketones, beta hydroxybutyrate, plasma amino acid. Look at the newborn screen for the galactose transferase enzyme, urine reducing substance, urine ketones, pyruvate, all these tests that you're reading over here, pyruvate, acetoacetate, carnitine, ammonia, lactic acid, this is all advanced workup. By now we have called endocrine, we've called the metabolic specialists. And then if nothing comes up, then now you're looking towards pancreatic tumors. And at this point, sending a proinsulin level and a C-peptide level is worthwhile. So I've repeated some things over here. Why have I said lactate over here and lactic acid over here? It's just because if you can send it earlier, that's good. If you can't, then this is a special test. And some hospitals, it'll be a send out. This I thought would be interesting to just get a global idea what we are dealing with. It's not, I can't put my finger on the diagnosis, but yes, this will guide me in some direction. So if you send a blood gas and there's no acidosis on it, no metabolic acidosis on it, and then the blood ketone levels are decreased and the free fatty acids are decreased, that means the baby has a lot of insulin. Because insulin doesn't let the counter-regulatory hormones come up. So hyperinsulinism, the counter-regulation is not good. Then if the ketones are not there, but the free fatty acids are floating around in plenty, then the fatty acid is not being broken down. So those are fatty acid oxidation defects. Then you come to acid, if the baby truly has acidosis, is that the ketones are increased, and here the glycogen is not breaking down, or there is a deficiency of growth hormone or cortisol, and the body is breaking down fat and there are more ketones coming up. And if the lactate is increased, that means that the gluconeogenesis is bad, and lactate is not getting converted back to pyruvate. These are global groups. So you are looking at a baby who has low glucose and has acidosis on the blood gas. First thing, clinical management, you're going to make sure you start IV fluids with dextrose. The baby could very well have sepsis. It is not necessary that this baby has or be a left heart. It's not necessary that we are only looking towards metabolic and endocrine disorders. And you will hear a lot about this tomorrow. I'm just touching upon this because when a specialist talks to me, I need to understand what they're saying. So I'm not going to pinpoint whether it is a carnitine disorder or a fatty acid oxidation disorder. I'll let them diagnose that, but I need to know to call them. So treatment is transitional hypoglycemia. First, ensure adequate feeding. If you have to give IV fluid, do that. Then when you get into the specific diseases, you have people helping you. Then we think of special formulae. We look at the medications and the hormones that we have to replace. And the hormones that I mentioned here were used earlier, but they are not first-line therapy anymore. And first-line therapy is after you've called endocrinology. They usually recommend diazoxide that acts at the same potassium-dependent channels in the pancreas. And diazoxide stops the release of insulin, but it also causes fluid retention. That doesn't work, then you step up to octreotide and glucagon and nifedipine, then start looking for pancreatic tumors. That is way down the road. We don't treat pancreatic tumors here. We have to send the patient out. Just a little bit about diazoxide. It causes fluid retention, hyperuricemia, hypotension, leukopenia, thrombocytopenia. It's not a benign medication. So if you have a 1,400-gram baby and the glucose is less than 60, you would try to increase the caloric intake so that the baby, in a way, the baby does not get NEC. And wait for diazoxide as a last resort, because that baby will retain fluid and get into trouble. So it is not, we don't use these medications unless it's absolutely necessary, a big term in front of a diabetic mother. So what do you tell the parents? That please let us check the glucose. Sometimes they don't want you to come in and prick their baby, and they don't understand why you want to do it. So you have to tell them, we really need to make sure your baby is fine, and explain the complications of hypoglycemia. Do not stop breastfeeding. Do not just console the mother and tell her, once your milk is in, you can get rid of the formula. You don't have to keep taking it. You don't have to keep giving it. And that is it. Glucose gel can only be given in the hospital. We cannot send babies home with that. So I don't know if I've gone too fast, but this is what I had to say. Any questions? It's cold stress. It's more like babies spend energy to keep their energy. So that's the stress factor. Maybe long number is and that is a huge factor. For us, when do we use it? You might have had a few babies where they put in a central line and the baby was at least 20 and stayed on these 20 and didn't get better. And then you would use diazoxide to help the baby come off the IV fluids. Then eventually, once the insulin regulation normalizes, then wean the baby off diazoxide. So only once you maximize that is what I would suggest now. If your attending wants to use it on a small baby, that's fine too. And I just wait because it's of the fluid retention and it's an oral medication. You can use it IV too, but it's a strong medication. It has a lot of side effects. So the main point that I want to say is that the main thing that as a neonatologist, hypoglycemia can be isolated, but it can be a neonatal illness also. Don't forget that. If you can't, in 3 or 4 or at the most 5 feedings, if the glucose is not normalizing, then it is now the insulin level. Most commonly, the insulin level is too high, and IV fluids are needed. So you should not keep the baby in contact with them. Thank you.